Okay, let's talk about the kids again. Child with alterations in gastrointestinal function, chapter 51. Okay, so the GI system of babies, especially neonates, are immature at birth, along with the liver function as well. This takes a while to start working and processing the enzymes that are needed to help take care of body's metabolism. So you'll see the enzymes are deficient until about 4 to 6 months old, and those are amylase, lipase, and trypsin. Abdominal distension from gas is common in babies and infants. And remember that the stomach capacity of these babies are much smaller than an adult. So compared to an adult, I'll show you a picture and you'll see that they're much smaller and contain much less milliliters. So the process of absorption and excretion doesn't begin until after birth. The infant does not have voluntary control of swallowing until they're about 6 weeks of age. Digestion takes place, if you'll remember, in the duodenum. And again, with that being immature, you're going to have the deficiency of those enzymes, which are used normally to digest carbohydrates. Lipase helps enhance fat absorption, and trypsin catabolizes protein into polypeptides and into some amino acids. So they need these enzymes for the digestion process. You'll remember this picture from class, just showing you the size of an infant's stomach on different days after delivery, day 1 through a month old. You see how the changes go with that. So the newborn's stomach capacity is about 20 mils. A 30-day-old would be about 90 mils, and a 1-year-old about 360 mils. Okay, disorders that we're going to talk about in the GI system are going to be structural defects, ostomies, inflammatory disorders, intestinal parasitic disorders, disorders of malabsorption, hepatic disorders, and injuries. All right, structural defects. These include defects such as cleft lips and cleft palates. Remember, there's other structural defects, but these are the two main in the gastrointestinal tract. As you can see, this definitely affects nutritional intake, so these babies have to be monitored closely for nutrition by watching their weight and other things we're going to talk about. All right, so normally the union of the upper lip is complete by about the 7th week of gestation. Infusion of the secondary palate occurs about 5 to 12 weeks into gestation, and approximately 30% of children with cleft lips and or palates will have another congenital anomaly going along with it. There's an increased incidence in families with a prior history of cleft lip or palate, smoking during pregnancy, maternal use of alcohol, and use of medications such as anticonvulsants and steroids during pregnancy. Remember, folate intake during pregnancy can help reduce the incidence. Okay, remember also with this cleft lip and palate multidisciplinary team is going to be needed to take care of these children. They're at increased risk for speech impairments, hearing problems, and definitely with dentation. Okay, so care as far as nursing care for these kids before surgery. We'll need to be using probably special feeding devices depending on the severity of the deformity. Okay, these include longer nipples. They're able to kind of bypass the palate, the cleft palate in the front, if that's where it is. Enlarge holes in the nipples so they don't have to suck so hard and make that seal. And also lactation consultants to help with breastfeeding techniques. Okay, cleft lip and palate, again, post-op care is going to include making sure that they're not rubbing their faces on their crib mattress or sheet and on blankets, because they can rip those sutures out and also lead to infection. So we'll use soft elbow immobilizers or restraints for up to about 2 weeks to help protect that incision so they can't get to it. Remember, with these kids, distraction and pain medication is going to be important to help keep them from hurting themselves. This is a picture of a cleft lip and palate. You can definitely see the repair on the cleft lip on the outside. Okay, assessment includes usually the cleft lip. It's going to be noticeable at birth, so observation. Cleft palate, palpating the primary and secondary palate with a gloved finger helps you to assess that area. Looking in the roof of the mouth with a flashlight also helps you look for smaller, less detectable holes in the roof of the palate. Also, we're going to be taking care of family at the same time. So remember, family needs to be told everything that's going on. They need to have a lot of support. They need to be kept updated. Okay, so a description of the location and the extent of the defect will help nurses to determine the correct feeding method for these babies. So a good assessment with a good description, again, will help decide how these babies are going to be fed and what different devices might need to be used. Remember, this deformity can be devastating to parents. A defect has been not corrected well or poorly corrected can lead to development of self-esteem issues for the older child, especially. Infants with cleft lip and cleft palate, remember, are prone to otitis media, so you do need to be thinking about positioning to help keep that from happening. And again, keeping them elevated, especially during and after feedings, is really important. Other nursing care measures involve providing emotional support again for family, performing post-surgical care, educating the parents on different feeding techniques, helping parents coordinate care and maintain healthy home environments, and making appropriate referrals. So one nursing diagnosis that can be used for a parent would be anxiety, and that would be related to a situational crisis, and threat to self-concept is another. These are very important for the family. Bonding, again, is a big issue. We want to really promote bonding with between parents and these babies. Another one is attachment or risk for impaired attachment related to the newborn structural defect. For the child or the baby, we're going to think about pain or acute pain due to surgical repair. Developmental delays, they're definitely at risk for those due to the structural defects and also due to the altered nutritional intake. So keeping them developmentally where they need to be is important to be working on that. Okay, for the baby, some additional ones are risk for aspiration. To help keep that from happening, definitely have your suction available at all times, whether it's a bulk syringe or suction equipment, other mechanical suction equipment. Position them in upright positions for feedings. Be sure to feed slowly and use the correct equipment that works best for that baby and their defect. Hold them upright for 30 minutes after feeding and burp them frequently. You want to burp them about every 15 to 20 meals or 30 meals, but 15 to 30 will probably do pretty good to keep that gas out of their tummy. Coping, family coping is another nursing issue. And that again goes back to pointing out the positive attributes of the baby, such as soft skin, long dark hair, whatever it might be. You want to pick out the good things and help them focus on that. Okay, so other post-operative care, we talked about this a little bit, keeping them from rubbing on the suture line, on the bedding or whatever it might be, maintaining those immobilizers, keeping steri strips over the incisions. And we want to use antibiotic ointment as long as that has been ordered by the physician on that incision site. Keep the baby's pain under control because we don't want them crying and really putting a lot of stress on that incision site or those sutures. And for cleft palate surgery, avoid using any kind of utensils that are metal, straws, anything that could cause damage to the roof of the mouth and the surgical incision. When oral fluids, we're going to begin those with clear liquid at the beginning, post-op. Then they're usually given through a dropper or a syringe or a special feeder. Identify and address home care needs with the family. Make sure they're prepared to take this child home once it is released. You want to do that before they're discharged. You want to teach them feeding techniques, how to recognize signs and symptoms of infection, how they need to position the infant, and how to take care of that incision line, that suture line when they go home. Okay, esophageal atresia and tracheoesophageal fistula. With esophageal atresia, the defect affects about 1 in 4,500 neonates. It's at about 90% of those affected also will have tracheoesophageal fistula. Other congenital anomalies occur in greater than 50% of children who are born with esophageal atresia. So esophageal atresia is a malformation that results from failure of the esophagus to develop as a continuous tube during the 4th and 5th weeks of gestation. With esophageal atresia and tracheoesophageal fistula, the foregut fails to lengthen and separate and fuse into 2 parallel tubes. So at some point, the esophagus and the trachea are either connected by a fistula, and the esophagus may end in a blind pouch. You can have a combination of different issues, but with both of them, you don't have 2 continuous tubes. Okay. Remember, this is associated with maternal polyhydramnios, too much amniotic fluid. There's a picture showing you the different types of normal anatomy. There's atresia. This has a fistula. And this one has both the atresia and the fistula. Remember the cardinal signs I told you about? This one says 3, but I gave you one extra one. So we're going to say 4. And that is coughing, choking, cyanosis, and apnea. And this is when it's diagnosed. This is the signs and symptoms and their cardinal signs. They'll have coughing when they're eating, choking, cyanosis, and apnea. This is the pathophysiology, closer-up picture. Esophageal atresia and tracheoesophageal fistula is is the upper segment again of the esophagus ends in that blind pouch, and it is connected to the trachea at some point through a fistula. And this is the most common type. Again, early signs are going to be excessive salivation and drooling. Classic signs are those cyanosis, choking, coughing, and apnea. So during feeding, the fluid returns through the infant's nose and mouth, leads to risk for aspiration and for pneumonia. You'll see a distended abdomen due to the air becoming trapped, not able to get out. Nursing care includes identifying these signs and symptoms, placing the infant with the head of the bed slightly elevated to minimize aspiration, continuous or low intermittent suction, and keeping the baby NPO. Pre-op and post-op care, again, so suction is very important. Have that available. There's the possibility of getting a gastrostomy too post-operatively, so care of gastrostomy too. And some babies may end up with TPN when they're not able to eat. All right, pyloric stenosis, no known etiology. Pyloric stenosis is a hypertrophic obstruction of the circular muscle of the pyloric canal. Pyloric stenosis occurs in approximately 2 to every 1,000 births, or sorry, 2 of 1,000 births. Symptoms you might see usually are evident when they're just 2 to 8 weeks old after birth. And we see an increased incidence of pyloric stenosis in firstborn males and more common in the white population. This happens between the stomach and the duodenum. Frequently, you're going to see a family history with pyloric stenosis. One consideration for what may cause this is hypergastremia, that is too much gastrin in the blood, and that is thought to play a role in the development of pyloric stenosis. Some studies have indicated a higher incidence of this disorder in infants who have received oral erythromycin before 2 weeks of age. All right, so the hypertrophy of the circular pylorus muscle results in stenosis or narrowing of the passage between the stomach and the duodenum. This causes it to be partially obstructed. And it obstructs the lumen of the stomach. The lumen will become inflamed and edematous. That's going to narrow the opening even more and makes the obstruction even more complete. Vomiting becomes more forceful. Infant is going to become dehydrated and electrolytes are going to be depleted. And this results in metabolic imbalances. Okay, this is a picture, just a little cheat sheet for pyloric stenosis. Remember, with pyloric stenosis, there may be a palpable mass. Peristalsis is visible. Excuse me. So you can actually see the peristalsis move across the abdomen. And projectile vomiting is a big indicator. So again, these usually become evident 2 to 8 weeks after birth. This infant is going to appear to be hungry, like all the time, especially after they have vomited. They're irritable. They'll fail to gain weight and have fewer and smaller stools. This child may present with dehydration and metabolic alkalosis to the hospital, and this will depend on how long the child has been vomiting. On an exam, you may see again those peristaltic waves, and they move across the abdomen as the stomach attempts to move the contents past that narrowed pyloric canal. So you might see an olive-sized mass in the right upper quadrant of the abdomen, and that's that little area sitting there that's not able to be passed through. So we want to assess this infant's history of vomiting to see what's going on, take vital signs. We're going to weigh the infant and check their nutritional status. We want to look at skin turgor, check the anterior fontanelle for dehydration. Remember, the fontanelles are sunken, that shows fluid deficit. If they are bulging, that shows fluid overload. Urinary output by weighing diapers, we want to check that. Specific gravity will help us know the concentration. And we also want to remember to look at their mucous membranes for signs of dehydration. We want to hear a description of the vomiting episodes. And if we see them, we want to estimate about how much it contains. Be alert for signs of electrolyte and or acid-base imbalances. So some nursing diagnosis of problems that you're going to see is fluid volume deficit because of the vomiting, nutritional imbalances, less than body requirements, and that's related to the vomiting and the inability to ingest those nutrients. Sleep pattern disturbances, that's related to being hungry, discomfort and hungry. Anxiety related to surgery for the parents, and then acute pain also for the baby. So with pyloric stenosis, surgery is usually performed as soon as possible after the infant's fluid and electrolyte balance is restored. You're going to see these babies be NPO pre-operatively. They'll have an IV to correct that fluid and electrolyte balance. Maintain nasogastric tube dissection if it is present. We want to measure output from that tube. We're going to weigh all diapers for output as well. We want to minimize weight loss as much as possible. So we're going to monitor their daily weight, both pre-operatively and post-operatively. We want to encourage rest and comfort. So pre-op, we want to swaddle these babies to help them maintain their warmth and provide them comfort. We want to encourage parents to hold them and cuddle them, use a pacifier for sucking, especially when they can't eat. Post-op analgesics. We want to avoid pressure on the incision site. You'll see parents normally lift their legs and feet up to put a diaper underneath the baby. At this time, with this with this surgery, you want to be sure and push the diaper gently up under the buttocks, rather than lifting them from the feet and legs. Swaddling, rocking, and using a pacifier are also important after surgery. So post-operatively, we want to make sure that incision is covered with steri strips and try to keep it as clean and dry as possible. Look at the incision for redness and swelling and other discharge because of the risk of infection. We're going to monitor the temperature every 4 hours, and we're going to listen to their lungs, auscultate their lungs to listen for any unusual breath sounds. Okay, gastroesophageal reflux. This is the return of the gastric contents into the esophagus, and it's the result of the esophageal sphincter relaxing. About 50% of these infants have some degree of reflux. Children or neonates at risk are those that are premature and those that have a history of a repaired esophageal atresia. These babies need to be held, be put in a horizontal position as much as possible. Okay, this can also lead to GERD, gastroesophageal reflux disease or disorder. Again, primary symptoms are regurgitation, spitting up, and vomiting. Again, frequently hungry and irritable. Loss of weight. Symptoms of GERD in the infant also include refusal of feedings, sleep disturbances, poor weight gain, respiratory symptoms that include coughing and choking and wheezing, and arching their back during feedings. Infants with reflux are at risk for aspiration and apnea. So GERD itself is a more serious manifestation of gastroesophageal reflux. And the symptoms are very similar to what we just talked about, but you do want to definitely watch for the coughing, choking, and wheezing that might be going on, arching of the back. Older children's symptoms may include dysphagia, heartburn, and chest pain. So when this stomach contents comes back up into the esophagus, it can cause damage to that mucosa. Things you're going to see is feeding modifications, thickened the foods, so thickened foods or feeds, and positioning are good management for milder cases of GER or GERD. A smaller feeding volume with increased feed frequency is recommended. And to help thicken the formula or the breast milk cereal might be added. In severe cases, a surgery in a gastrostomy tube might be necessary. Nursing management, again, focuses on supporting the infant or child's nutritional intake, promoting interventions to reduce other complications, and supporting the family. Adequate nutrition must be maintained for the child to have normal growth and development. Adequate nutrition. We want to try to reduce any other complications. So again, we're going to remind parents to hold their infant in an upright position for at least 20 to 30 minutes after feedings. We want to minimize seated position of these infants, such as in an infant car seat, because this increases the intra-abdominal pressure and promotes reflux. So no, we don't want to sit them in a car seat or a baby carrier during feedings or after feedings, again, because it increases abdominal pressure. Okay, omphalocele and gastroschisis. Omphalocele, the size of the omphalocele, that's the penetration of the bowel through a sac, and the size of the sac depends on the extent of the protrusion of the abdominal content that it contains, and that goes through the umbilical cord. About 20% of infants with gastroschisis will have another anomaly going on, and that's often atresia or intestinal stenosis. Both of these, gastroschisis and omphalocele, are associated with elevation of the maternal serum alpha-fetoprotein during pregnancy. So with the gastroschisis, is a protrusion of the bowel through a defect in the abdominal wall to the side of the umbilicus, which is different from the omphalocele that goes through the umbilical cord. Okay, treatment for both of these is surgery. Here's a picture of omphalocele contained in the bag, both of these, and that is through the umbilical cord. Okay, so care of the child with gastroschisis or an omphalocele, they're both going to be similar. Centers on protecting the protruding abdominal organs, correcting the defect, and then preventing complications such as hypothermia, infection, and injury to those organs that are involved. Immediate action upon birth is to protect the sac in the omphalocele or the exposed abdominal contents in the gastroschisis. Protect them from injury by placing the infant feet first into, it's called a bowel bag. It's a large, sterile, clear bag. That extends to the nipple line upon the infant, and then it's going to be secured with ties. The bag is filled with warm saline to decrease heat loss and to keep the organs moist and to allow for visualization of the defect. Okay, so this is omphalocele on the left and gastroschisis on the right. Gastroschisis itself is a congenital defect of the abdominal wall. Again, the bowel goes through the abdominal wall to the side of the umbilicus. So the abdominal contents are on the outside of the abdominal wall. Nursing management, We're going to be alert for signs of other congenital anomalies that might be present right after birth. We're going to have to follow the provider or facility protocol for maintaining that sac or the exposed contents. Usually it is like the bag we just talked about. There are some other ways that is handled depending on the facility. We want to monitor vital signs at least hourly and especially monitor the temperature because they're at very high risk of becoming hypothermic. These babies should be placed in a warmer or an isolette to help maintain temperature control. Okay, intussusception. This intussusception is when the intestine actually invaginates or moves into another part of the intestine. It kind of slides inside. The lining becomes inflamed, and then obstruction can occur when it happens. It's caused by many different reasons, and a lot of it's unknown. You diagnose intussusception by history. Parents will tell you what's been going on. And they can also use the contrast enema, which is usually air or barium, to help diagnose intussusception. With the air being used with the enema, the air can also be a treatment rather than a diagnostic tool. And the air helps move that intussusception back out and reduces it in about 90% of the time. If the air enema doesn't work, then they are at risk or they will need surgery to correct that area. So it's kind of like the intestine telescopes into or prolapses into the other part of the intestine. It's one of the most frequent causes of intestinal obstruction during infancy. It occurs in about 1 in 2,000 infants and children. It's more common in male babies. And about 65% of cases occur in children before age 1. Intussusception is commonly associated with viral illnesses and gastroenteritis. The most common site for intussusception to happen is the ileocecal valve. Intussusception, the signs and symptoms usually start abruptly, very quickly, and the child suddenly experiences acute abdominal pain with vomiting and starts to pass brown stool. The child may have a bile-looking emesis and a palpable abdominal mass as well. Stools will become red and kind of resemble a currant jelly. With intussusception, a nasogastric tube is usually inserted to help decompress the gastric area. If the reduction of the intussusception does not occur with the contrast enema, like I said, surgical intervention in order to reduce that bowel and to remove any necrotic tissue will be necessary. For post-op care, we want to monitor early signs of infection. We want to manage the baby's pain, maintain nasogastric tube patency, keep that stomach decompressed. We want to assess vital signs, check for abdominal distension, and we watch for return of bowel function. Okay, volvulus. About during the 7th to 12th week of gestation, the small intestine undergoes rapid growth, and this happens early on. This happens rapid growth, sorry, and then about 1 in every 500 live births have a volvulus. Early diagnosis and treatment is necessary in order to preserve the bowel and to save the child's life. This is a medical emergency that requires surgery. So symptoms For the infant include bilious vomiting, a firm abdomen with distension, irritability secondary to pain, and passage of bloody stools. So you can see in this picture of ovulus, is the rotation right here of the intestines that can become blocked and necrotic. So nursing management is keeping the child NPO, administering IV fluids, and assessing their vital signs for worsening condition. If necrotic bowel was present, it would have been removed during surgery. So in this case, the child may need an ostomy for some period of time to allow that to heal. Hirschsprung's disease, also known as congenital ganglionic megacolon. It's a congenital anomaly in where they have inadequate motility, and that causes mechanical obstruction of the intestine. The disease occurs in about 1 in 5,000 births and is more common in males than females. So with this disease, it's a congenital absence of the ganglion cells or nerve cells that are in the wall of a variable segment of the rectum and the colon. So those nerve cells are missing, ganglion cells are missing from that section, that segment of the rectum or colon. Absence of these autonomic and their parasympathetic ganglion cells in the colon prevents peristalsis from happening at that portion of the intestine. And this results in accumulation of intestinal contents and abdominal distension. Symptoms in newborns are going to include abdominal distension, feeding intolerance, bilious vomiting, and failure to pass meconium within the first 24 to 48 hours after birth. So one of the big signs is when you have a newborn baby, our nursing job is to really watch those babies for meconium passage within the 24 hours that they're there. So failure to pass that meconium within 24 to 48 hours after they're born is a sign, a big sign of Hirschsprung's disease. The older infant or child may have a history of failure to gain weight, or a history of malnutrition, and chronic severe constipation. Primary repair of Hirschsprung's disease to remove the ganglionic portion of the bowel is done usually through a pull-through procedure. You can see what this procedure looks like in your book. This is just showing you a picture of a normal intestine, and then this intestinal wall, this is where the lack of nerve cells are. So the contents build up and cause it to become really big in the intestine with a megacolon, which causes the abdominal distension. So nursing management, careful observation for the passage of meconium again, monitoring for infection, managing pain, maintaining hydration, measuring the abdominal circumference to detect any distension or distensional changes, and providing support to the child and family. Anorectal malformations, such as anal stenosis is a narrowing and anal atresia are a couple. Failure in the growth of the urorectal septum, lateral mesodermal structures, and ectodermal structures. So this is the 1 in 5,000 live births worldwide. Anorectal malformations are frequently associated with other anomalies as well. Presence of 3 or more of the following anomalies, and that is vertebral anomalies, anal atresia, congenital heart disease, tracheoesophageal fistula, and renal abnormalities, excuse me, and limb defects. That is the Vactry conditions, those other associations. So diagnosis of an anorectal malformation is usually made at birth or during the newborn assessment of the anorectal structures and rectal patency. When the baby is first delivered, the nurse normally checks for rectal patency before they are fed. Nursing management is perineal area is inspected for poorly developed anal dimple or sacral anomalies. So you really want to look at these babies closely when they're born. Observe and report passage of meconium again. IV fluids, nasogastric tube is usually inserted to decompress the stomach. Monitor INO, very important, and cardiovascular functioning as well. We want to provide, again, emotional support to the parents. Post-op, these babies will have a Foley catheter placed for about 5 days to help protect the new anal opening from urine and becoming contaminated with urine. Colostomy will be in place to protect the surgical site, also from stool. Nothing placed in the rectum should be the standard rule to go by. Provide adequate pain management for these infants, and maintain those IV fluids until the child is able to take and keep down liquids by mouth. Congenital diaphragmatic hernia. This is when abdominal contents protrude into the thoracic cavity through an opening in the diaphragm. The cause is a delay or failure of closure in the pleural peritoneal musculature, which forms the diaphragm. A diaphragmatic hernia is a life-threatening condition with an overall mortality rate of 20 to 35%, up to 50% in infants born alive with this condition. Severe respiratory distress secondary to the pulmonary hypoplasia occurs shortly after birth, almost immediately. When the infant cries, it causes abdominal organs to extend up into the chest or thoracic cavity, and this decreases the size of the thoracic cavity. The infant becomes dyspneic and cyanotic. Characteristic findings include a barrel-shaped chest and sunken abdomen. So that sunken abdomen is due to the lack of the gastrointestinal contents because they're up into that chest area, causing the barrel shape. Normally these are diagnosed early while the mom is pregnant in utero with ultrasound. This is a picture of the gastric contents right here, being up into the chest cavity and not in the abdominal cavity. So immediate respiratory support is essential for these neonates, these babies that will be in a high-risk intensive care unit. Ventilator support is going to be necessary to manage respiratory compromise. Conventional mechanical ventilation, high-frequency oxygen ventilation, nitric oxide, and along with extracorporeal membrane oxygenation, which is ECMO, are the main methods used to treat respiratory failure in these kids. The infant's positioned with the head and thorax higher than the abdomen to help facilitate the downward movement of the abdominal organs down into the abdominal cavity. Once the infant's condition is stabilized, the defect is corrected surgically. Nursing management is continuous monitoring in a NICU environment. Observe for worsening of respiratory compromise. We're going to maintain IV fluid hydration. Promote decreased stimulation to these infants to keep the infant calm. And this maintaining low abdominal pressure when they're calm and not crying. We want to keep parents informed about the infant's condition continually and provide emotional support both before and after surgery. And that's Charlie again. Okay, umbilical hernias. With umbilical hernia, the omentum and small intestine is herniates or protrudes through the opening with coughing, crying, and straining during a bowel movement. So those protrude more. So if they're diagnosed before 6 months of age, most will resolve spontaneously by about 1 year of age. If surgery will be indicated in those cases of strangulation, where the closure of the muscular ring around that bowel happens and it prevents it from moving back into the abdomen. So that would be a requirement for surgery. Also recommended surgery if the defect does not resolve by about 4 or 5 years of age. And that's a picture of umbilical hernia. Nursing management, instruct parents not to apply tape or straps or coins to reduce the hernia. I don't know if you guys have seen that. I've seen them have coins on, $50, big quarters to help keep it pushed in. But that's not been a proven method of treatment or a successful method at this point. Post-operatively, teach parents how to care for the surgical site, how to watch for bleeding, and recognize signs and symptoms of infection. Ostomies or stomas is the opening in the intestine to divert fecal matter. This can be temporary or permanent. An intestinal ostomy, again, or a stoma, is open. Goes into the small or the large intestine to divert that fecal matter. It provides an outlet when a distal surgical and that. Sorry, I can't talk right now. I'm gonna get a drink. Hold on. Okay, so it provides an outlet when there is an obstruction. Ostomies can be temporary or permanent. It affects the child's lifestyle. Remember about altered body image, very important for a child. It can cause anxiety and increases the risk for alterations in physiologic processes such as electrolyte imbalances, increased nutritional requirements. For adolescents, it may be a result in a dependence on a colostomy or an ostomy at a major developmental area in their lives, so it can become a real problem. When autonomy is really important. That's a picture of some ostomies. So this infant has several gastrointestinal problems and requires ostomies for gastric feedings and for drainage of fecal material. And you can kind of see the little healthy stoma under the clay dressing on that first one. Post-operative care of this child with an ostomy is similar to that of other children who undergo abdominal surgery, adding on management of the stoma. Okay, inflammatory disorders. Meckel's diverticulum. So clinical manifestations of this usually appear by age 2. Meckel's diverticulum is most commonly presents as GI bleeding or obstruction. The child generally presents with bloody stool, irritability, fatigue, abdominal pain, and distension, nausea, and vomiting. Nursing management. Preoperatively, you want to have an IV infusion to correct fluid and electrolyte imbalances. We want to monitor INO, observe for rectal bleeding, and test stools for occult blood or blood that's present in small quantities. Keep the child on bed rest, assess vital signs at least every 2 hours, and monitor for signs of shock. Post-operatively care is similar to that for an infant or child undergoing other abdominal surgeries. the rule of twos, which you can see right here. Okay, appendicitis. Appendicitis is caused by an obstruction of the appendiceal lumen, causing edema. As this edema increases and continuous vascular supply is compromised, and bacteria are able to get in and invade it, which can lead to a ruptured appendix. So signs that you may see, you can abbreviate with pains or acronym it with pains. Pain, anorexia, increased temperature, nausea, and signs. Appendicitis, let's see, again, is an inflammation of the veriform appendix. It's the small sac that's near the end of the cecum, and it's the most common cause of emergency surgery in children. Young children have a higher incidence of a perforated appendix. Symptoms you might see include periumbilical cramps, abdominal tenderness, anorexia, nausea, and fever. Pain in the right lower abdomen will become more constant. The area called the mid-burning point, pain is often the most intense there, and that is halfway between the anterior superior iliac crest and the umbilicus. Symptoms will progress to include guarding, rigidity, nausea, vomiting, onset of pain before vomiting, anorexia, and rebound tenderness following palpation over that right lower quadrant. As appendicitis progresses, the child remains motionless, usually in a sideline position with their knees flexed. Sudden relief of pain usually means that the appendix has ruptured or perforated. Okay, so here are some nursing care. Preoperatively, the child is kept in PO. IV fluids and electrolytes and antibiotics are administered. Treatment of uncomplicated appendicitis involves immediate surgical removal and appendectomy. Postoperatively, the child with that perforated appendix may have a nasogastric tube to decompress the abdomen and will remain in PO until signs of bowel function return. Bowel function is best indicated by passage of air. Okay, peptic ulcers. Peptic ulcer is an erosion of the mucosal tissue in the lower end of the esophagus in the stomach, often caused by Helicobacter pylori, or you may know it as H. pylori. The most common symptom is abdominal pain, may be described as a burning, and it's associated with an empty stomach. This may awaken the child at night even. Vomiting and pain after meals, anemia, occult blood in stools, and abdominal distension may also be present with peptic ulcers. Nursing management includes assessing the child for abdominal pain, vomiting, and abdominal distension, assess for family history of H. pylori infection, and nursing care is going to center on interventions to promote adequate nutritional intake. Okay, inflammatory bowel diseases such as Crohn's disease and ulcerative colitis. Inflammatory bowel disease encompasses those two distinct chronic disorders that have similar symptoms and treatment. Inflammatory bowel diseases differs from irritable bowel syndrome. That is very different. So in Crohn's disease, it's a chronic inflammatory process. There's a strong evidence to support genetic association. It most often develops in adolescents and young adults. This disorder occurs randomly through the GI tract, with the ileum, the colon, and the rectum as the most common sites. A distinct feature of Crohn's disease is the development of enteric fistulas between loops of the bowel and nearby organs. A distinct feature, oh, never mind, sorry, it's those fistulas. Okay, with ulcerative colitis, it's a chronic recurrent disease of the large intestine and the rectal mucosa. Unknown etiology, don't know what causes it. Inflammation is limited to the mucosa. The disease develops before 20 years of age, usually, with the peak onset at about 12 years old. First symptom of ulcerative colitis is usually diarrhea, and then may move into lower abdominal pain and cramping that become present before and during a bowel movement and are relieved by the passage of stool and flatus. The stool is often mixed with blood and mucus. Weight loss or delayed growth, nutritional deficiencies, and other arthralgias often occur as effects from this disease. This is the comparison chart. This is should be in your book as you compare the two. Like I said, they are kind of similar. They're treated very similarly, but they occur in little bit different places. Okay, for Crohn's and ulcerative colitis, they do have periods of remission and periods of exacerbation. Treatment for both diseases include pharmacologic interventions, nutritional therapy, and in severe cases, surgery. Nursing management is mainly done in the community and from home. It focuses on helping the child and family emotionally adjust to the impact of chronic diseases. It includes administering medication and diet therapy, monitoring nutritional status, and providing appropriate referrals. Remember, with these kids, body image is a major concern. The children and adolescents. This is necrotizing enterocolitis. It's an inflammatory disease producing vascular compromise of the bowel mucosa. More common in premature infants, is caused by intestinal ischemia, bacterial or viral infection, and immature gastrointestinal mucosa. Necrotizing enterocolitis is a potentially life-threatening inflammatory disease of the intestinal tract, and primary again in those premature infants. It's associated with a mortality rate of 5 to 24%. So the etiology of what causes it is multifactorial again. Intestinal ischemia and inflammation. We already talked about that bacterial and viral infections as a result of premature infants' decreased immune response and greater risk for infection. Enteral feeding and immaturity of that gastrointestinal mucosa can all be contributing factors. You may see bloody diarrhea because of the hemorrhagic bowel. The condition progresses to lethargy, periods of apnea and bradycardia, and temperature instability. Treatment is going to include bowel rest, which means NPO status, gastric decompression with the nasogastric tube, and antibiotic therapy. We want to observe for feeding intolerances by aspirating the gastric residual. So the infant is as if they're receiving enteral feedings. See if they have residual left over. Measure abdominal circumference and assess bowel sounds in the premature or high-risk infant every 4 to 8 hours. Even minimal changes in circumference of the abdomen can indicate necrotizing colitis or enterocolitis and should be reported immediately. Okay, malabsorption disorders, problem with absorption. That would be your short bowel syndrome. That's when the bowel is shortened. maybe from bowel resection. The amount of the bowel that's been lost determines the severity of the disorder. And also the location of where it happens or is lost will help determine the type of malabsorption. So short bowel syndrome is a decreased ability to absorb and digest a regular diet. Excuse me. Okay, sorry. Is the decreased ability to absorb and digest a regular diet due to that shortened intestine, which leads to malabsorption and occurs when a child cannot digest or absorb nutrients in the diet. Loss of the intestine may result from extensive bowel resection for treatment of necrotizing enterocolitis or inflammatory disorders, or even from congenital bowel anomalies. The section lost, or bowel lost, determines the particular vitamins and other nutrients that are inadequate for the child. The child with short bowel syndrome will receive TPN via central line. Aseptic technique in the care of the central line is essential because we don't want that to become infected for sure and lead to sepsis. Motility disorders. Gastroenteritis is an inflammation of the stomach and intestines that may be accompanied by vomiting and diarrhea. Infants and small children with gastroenteritis or diarrhea can quickly become dehydrated and are at risk for hypovolemic shock, especially if the fluid and electrolyte losses are not replaced. Treatment is oral rehydration therapy is the first intervention. For severe dehydration, rehydration is accomplished through IV infusion with a solution chosen to correct the electrolyte imbalance. Antiemetics and antidiarrheals are generally not used in young children since they can mask or cover up the signs and symptoms of more serious illnesses. This is a description of what's causing each of these areas. This is the table 51-2 that's in your book, so you probably want to take a look at that. Constipation and encopresis. Constipation during infancy is rare and is most often caused by mismanagement of the diet. Dietary management is the treatment of choice for constipation that has no underlying pathologic cause. Constipation in young infants can usually be corrected by increasing the amount of fluid or by adding 2 ounces of pear or apple juice to their daily intake. Increasing physical activity and fluid intake may be effective for some children. Encopresis is reported to occur in about 3% of children ages 3 to 12. Children with primary encopresis have never achieved bowel control. Encopresis is an abnormal elimination pattern characterized by the recurrent soiling or passage of stool at inappropriate times by the child who should have achieved bowel continence by then. Prevention of encopresis is the nursing goal. You want to partner with parents to help teach toilet training techniques, emphasizing the child's developmental readiness. Removing constipating foods such as bananas, rice, and cheese from the child's diet often decreases constipation. Increasing the child's intake of high fiber foods such as whole grain breads, raw fruits, and vegetables, and fluids also promotes bowel elimination. In older infants, increasing the intake of fluids, cereals, fruits, and vegetables in the diet should correct the problem. A single glycerin suppository or enema may be required to remove hard stool for some children. Intestinal parasitic disorders. These are common in tropical regions where there's untreated water, incorrectly prepared foods, and poor sanitation areas. Outbreaks take place where, again, water is not treated, incorrectly prepared food, and people living in crowded conditions, such as with poor sanitation. In the United States, outbreaks of diseases caused by protozoa or helminths, which are worms, are increasing. Common cause of young children infections is exposure to pets and wildlife. We want to, as nurses, emphasize the importance of good hygiene practices, especially careful hand washing after toileting and after handling food or when handling food. Ensure the family understands proper medication administration. Instruct parents on administering prescribed medications as directed, even if the child's condition seems to improve. A lot of parents will stop way too early, so they don't really get rid of the infection. Short bowel syndrome. Oh, never mind about that. I don't know why I have that there, sorry. Okay, so that's parasitic disorders. Hepatic disorders. Biliary atresia results when the extrahepatic bile ducts, they fail to develop or are closed. This disorder will lead to cholestasis, cirrhosis, and portal hypertension, also to end-stage liver disease and death by 2 years of age if it's not treated. Biliary atresia is the leading indication for pediatric liver transplantation. Viral hepatitis. Usually the nurse encounters the child and family in an outpatient setting. In addition to observing the child for characteristic signs of hepatitis, such as jaundice, skin, and the sclera, we want to assess for abdominal pain, anorexia, nausea, vomiting, malaise, and arthralgia. A history of the child's contacts in the past several weeks may also need to be obtained. For an infant, the hepatitis history of the mom and other family members is important. For a liver, remember, its primary function is production of blood clotting factors, fibrinogen and prothrombin, secretion of bile and bilirubin, and metabolism of fat, protein, and carbohydrates. It also detoxifies detoxification of hormones, drugs, and other substances, and it stores vitamins A, D, E, and K, and glycogen. Okay, with viral hepatitis, remember, it can lead to more liver damage and lead to cirrhosis. Cirrhosis can occur in children of any age, especially at the end stage of several disorders such as hepatitis and biliary atresia. Parents of a child with cirrhosis are coping with a life-threatening disorder, and their anxiety and stress levels are very high. The child may be awaiting a liver transplantation that represents the only hope for this child to survive. So it's a very stressful environment. Signs of hepatic disorders are jaundice, easy bruising and intense itching, white or clay-colored stools, and tea-colored urine. Nursing care is going to include emotional support, TP baths, rest, patting the skin, teaching and doing patting the skin rather than rubbing the skin, and weigh infants daily. These infants may be on TPN, lipids, and fat-soluble vitamins such as A, D, E, A, and K. This is hyperbilirubinemia in the newborn. Jaundice may not be detected until about 2 or 3 weeks after birth. Bilirubin levels increase accompanied by abdominal distension and hepatomegaly. As the disease progresses, splenomegaly also will occur. The infant will experience again easy bruising, prolonged bleeding times, and intense itching. Stools have that putty-like consistency and are white or clay-colored because of the absence of bile products or pigments. Excretion of bilirubin and bile salts result in tea-colored urine. We want avoidant restrictive food intake disorder, that is failure to thrive, and malnutrition can occur as the destructive changes of the disease progresses. So avoidant restrictive food intake, failure to thrive. This is table 51.4, comparison of different hepatitis types in your book. So take a look at that. Just know a little bit about the differences in them. Hepatitis itself is an inflammation of the liver caused by a viral infection. Hepatitis may be an acute or chronic disease. Acute hepatitis is rapid in onset, and if it's untreated, it may develop into chronic hepatitis. The most frequently diagnosed causative organs for hepatitis or organisms are hepatitis A virus, hepatitis A virus, hepatitis B virus, and hepatitis C virus. A lesser known type is hepatitis B. Hepatitis E occurs primarily in developing countries and is not often seen in the U.S. Symptoms of acute viral hepatitis infection include nausea and vomiting, fatigue, abdominal pain, joint pain, pruritus, and urticaria in the prodromal phase. In the enteric phase, the child develops jaundice, the gray or pale colored bowel movements, gastrointestinal symptoms, and right upper quadrant pain and malaise. The spread of viral infections can be interrupted by elimination of the virus from the infected population, institution of proper hygiene, and passive or active immunization. But until now, there's no antiviral agents being developed for hepatitis viruses. So right now, prevention depends on breaking the cycle of infection. Okay, injuries, abdominal trauma for abdominal trauma injuries. These blunt trauma is the most common penetrating injury. It accounts for about 10 to 20% of pediatric trauma admissions. Gunshot wounds are the most common cause of penetrating injuries. Other causes will include stabbing or impalement of an object. Children are more likely than adults to sustain abdominal injuries because of their small, pliable rib cage and less developed abdominal muscles, which provide not much protection for major solid organs, such as the spleen, the liver, and the kidneys. The solid organs in children are also larger in proportion to their body size compared to adults, so therefore more vulnerable as well. Other abdominal traumas besides injuries, blunt injuries, falls, motor vehicle accidents, pedestrian accidents, child abuse. So remember, a child that's restrained in one lap belt in a car or in a vehicle are more likely for abdominal injury, to sustain abdominal injury. We want to assess the abdomen for bruising, pain, guarding, rebound tenderness, distension, and obvious signs of injury such as bruising. Monitor hematocrit and vital signs every hour is warranted to detect hypovolemia. We want to watch for tachycardia and hypotension. This may indicate hypovolemia or internal bleeding. Strict monitoring of intake and output will provide information about the child's fluid status. We want to monitor respiratory status because abdominal injuries may also have thoracic involvement. The child with thoracic injuries may not take deep breaths well because it's too painful. Okay, the spleen and the liver are the organs most commonly involved with that blunt abdominal trauma. Treatment of the liver and spleen focuses on preventing or managing hemorrhage and monitoring for signs of shock. An IV infusion is indicated for fluid maintenance and to provide access for blood products. The child is kept NPO. They'll have a nasogastric tube inserted. And again, blood transfusions and pharmacological management are used to treat blood loss. Clinical manifestations, you're going to see the child with pain, abdominal distension, guarding, decreased or absent bowel sounds, nausea, vomiting, signs of hypotension leading to possible shock, and then those physical wounds, penetrating wounds, bruising, and other marks. Nursing care, nursing management, assess the abdomen again for bruising, guarding, rebound tenderness, distension, and obvious signs of injury. Monitor the vital signs closely again, watching for hypotension and shock. Follow specific physician orders. Provide emotional support to the child and the family. And prevention teaching is important for family. Okay, that is it for GI, pediatric GI. I hope this helps. Good luck on your test.